Thanks for the introduction. So my name's Tyner, and I'm a surgeon here in town. Actually, we have a practice around the corner that's aimed at bariatric surgery, and that's what I was doing this morning, and we'll be doing a little bit here in the afternoon. But my background as a surgeon is that, let's see, when I finished training, a long time ago, 1988. And not long after that, about 2 years later, they came out with the idea of laparoscopic surgery. Started taking gallbladders out in 1990. And in 1991, some guy figured out how to do repairs of hiatal hernias with a laparoscope. And in 1991 and a half, I started doing it. So my background goes way back in terms of fixing hiatal hernias and aimed at dealing with reflux disease. So I'm a surgeon, and I tell people, don't be misunderstood. I operate on reflux patients. At the same time, I spent the last 20 years trying to figure out how to help people manage a problem medically, so hopefully they don't need me as a surgeon. So anyway, I got a long background with reflux disease, and again, I do kind of look at it as a surgeon, but we don't operate on anybody unless they've been through every medical trick there is. So that's sort of where I come from in all this. All righty? The word that most people start with is the word reflux, and in the doctor world it's called GERD. I don't know, anybody heard of GERD before? Yeah, so that's gastroesophageal reflux disease. All right? And when patients come to see me and they say, gee, doc, I've got reflux, to me, reflux is this huge basket that holds all the problems that go with acid reflux. All right? And when I start chatting with patients, I try to break it down because not everybody shows up with the same set of problems. There's heartburn, and most people kind of get that one. Fire in there. There's issues of chest pressure or chest pain. And there are a few folks that show up who's thinking they have a heart attack. Pain can also be a sense of just intense pressure. That's my thing when I get it. Some people hurt in their back. There are a few weird people that hurt in their shoulder. But pain can be a part of it, and sometimes it's because the acid has actually, or contents from the stomach, and generally acid, can come up into someone's esophagus, and in and of itself it can cause spasm in the esophagus or the swallowing tube, and that can cause pain. If the stomach starts to creep into the chest, and that's called a hiatal hernia, and I'll explain sort of how you get one of those in a minute, but sometimes just the stomach sitting in the chest can cause pressure. And again, it might not be associated with heartburn, and or patients may not feel anything come up, so it can be an issue. Then the next thing is a cough. It's this weird thing, you can drip acid into the esophagus of rats and they'll cough. And there's this, when acid or bile creeps into someone's esophagus, you get this nerve reflex, and it's sort of like if you take your knee and you hit it like that and your foot swings out, there are nerves in your esophagus that tell your brain acid's on the way up, get ready. So it'll actually make the patient cough because the body's thinking whatever's coming up may end up in the lung. So patients show up with a chronic cough and they can't get fixed. And I've had patients who've had to put a sign on their door in their office saying, I'm not infectious, just because they're coughing and people think they have TB. And then from there up, if acid can get to here, it can get to here. And one of the common set of patients that we see are people with hoarseness and weakness in their voice, because the tissues right on top of the vocal cords get angry, and the vocal cords themselves can get little polyps on there from acid just sort of trickling in at night when they're lying down. So we see a lot of patients from the ear, nose, and throat doctors because they have a chronic hoarseness or weakness in their voice. And the other thing that affects ear, nose, and throat patients is this issue with chronic sinusitis. And the number one reason for failed sinus surgery is because patients are refluxing and they don't know it's getting all the way up to here. All right, so 75% of failed sinus surgery, patients will have silent reflux, which means they can have acid coming up and not have heartburn and not have chest pain, things like that. And there's all kinds of tests that can be done to prove that there's acid getting to right there. Okay? So when I hear reflux, I try to get patients to break it down a little bit so that we can all be sure about the various things that that might be going on if you just listen to the symptoms. All right? Any questions about that? Anybody got reflux? I'm trying to look and see what people are eating because, one, I'm hungry, and B, it comes into play. So heartburn, chest pain, regurgitation, asthma, I didn't mention that. Same thing when these nerves get activated in the esophagus, and if it trickles into the back of the vocal cords and just gets pointed towards the windpipe, the lung becomes reactive. So a large number of adult onset asthmatics are there because they have reflux. And I had a lady once who was on 120 milligrams of steroids every day because her lungs were so reactive, and we stopped her reflux and she quit. And it was within a month. And the lady had been suffering for a long time. All right, so that's the big box of things that go with reflux disease. And I explained sort of the anatomy of someone's esophagus, all right, and how things work in there. Your swallowing tube starts about right there and goes down behind your heart, and it comes through a hole in the diaphragm. It's called the hiatus. I took Latin in high school, not typing, so if you watch me today put orders in a computer, you'll figure out which one I did better at. A hiatus is Latin for opening, and it's the biggest hole in your diaphragm that things go through. All right, your esophagus fits through this muscular opening. It's about like that, and the swallowing tube comes through there, and it hits the stomach. In a perfect world, about that far, that's your esophagus, about that far below that hole right there. All right, so your swallowing tube is supposed to come in there, and your esophagus doesn't come in literally at the top of someone's stomach, and it should. I'll tell you this, I have a brother who's a tattoo artist, okay? He's very good. And I went the other way. Anyway, so the swallowing tube comes in on the stomach, and it sort of sits about like that. All right? So there's a little stomach up above where the swallowing tube comes into it, and it comes in at a dent right there. So again, in a perfect world, food would come down your esophagus, swill around in here, and go this way instead of that way, because of that little dent right there. And if you're early surgeon, some guy in Germany a couple hundred years ago figured out a name for that, so we have a fancy name for it. But anyway, the other thing that's supposed to happen, the swallowing tube squeezes, the word we use is peristalsis. It's supposed to squeeze with a nice little rhythm, and it pushes down, but there's a muscle at the end of the esophagus that's supposed to be like that. It's shut more than it's open. So when this thing squeezes, everybody swallowing okay right now? So what happens, by the way, when you guys start a drink or swallow, you get it to right there and Mother Nature takes over. You don't have to tell the esophagus to keep squeezing. And this is supposed to squeeze rhythmically, and then when it hits right there, this sphincter is supposed to be shut. So I don't know, anybody here have endoscopy before? Have a light down there? So in a perfect world, you go down someone's swallowing tube and you hit kind of a shut door, and then you pop through it into the stomach. But if this thing is weak, then obviously things can go back. But this is supposed to stop things from going backwards, and this little angle right here is supposed to stop things from going backwards. For what it's worth, if this muscle is weak and it's not pinching well, then things can come back up. And there's a couple of things that can make that thing weak so that you can have reflux unintentionally, all right? And I was thinking about a story. When I was a kid, there was an eating contest. And my personality is I hate to lose. I just do not like losing. So I didn't care who was sitting next to me. I was going to out-eat them. And then I was miserable. And my mom told me to go brush my teeth. And I thought she was absolutely nuts. All right? Anybody heard of this? Brush your teeth to make distension better? It has mint in it, right? Toothpaste with mint causes this muscle to relax. All right? So then you can let a little steam off if you've overdone it like I did. And I was crying. That's how much I ate. But anyway, so certain things make that sphincter worse. I don't know what the fanciest restaurant in town is, but anybody know what they give you? What's an after-meal thing to do? Mints, one. What's the mints with? Chocolate mints. And what else do they do? What else can you do after a meal? Drink coffee. What else? What is that stuff my partner likes? Drambuie? No, what's... Granbury. Okay, so they have all these after-meal drinks, right? Why do you get them after a meal? Coffee, chocolate, mints, onions you don't get after a meal, alcohol, they all cause this muscle to relax. So if you've overeaten, it lets a little steam off, all right? Which is nice, unless you're a refluxer already, and that muscle's weak, and you throw this into the mix, and then you're going to really have reflux, all right? And I will tell you, I love Vidalia onions, but it's a death sentence. I mean, I just can't eat them, right? And that started for me about 10 years ago for some reason. And then there's one, since it's a women's meeting, Fosamax. Anybody here on Fosamax or Boniva, things like that? It's for osteoporosis. It helps solidify, or what's the word? It inhibits your bone from breaking down itself to give up calcium. But Fosamax, as it turns out, is a very dramatic relaxer of that thing right there. And we've had some patients who show up, have been on Fosamax for 6 months or a year, and all of a sudden they just have raging reflux. And as it turns out, when you stop it, it won't necessarily correct itself. All right? So it can be an issue.
What causes the muscle to be weak to begin with?
Well, I'm going to talk about a couple of things, but some kids are born with it. All right? I learned to do this surgery in pediatric surgery. I saw a kid this big get his second operation for this. All right? I mean, so it happens. And I do some missions work in South America at a children's hospital, and it's a fairly common thing for us to do down there. For me, I'm not a pediatric surgeon, but because I'm down there, they don't ask me that. But anyway, I did train with that. But so anyway, it's a common thing. Kids can be born with an ineffective sphincter.
So it's genetic?
Yeah, well, it can be genetic. It runs in families. But if you can imagine you're heaving to have a baby, think about all this pressure on your diaphragm, all right? Yep. And I'm going to explain a hiatal hernia when I get to that, all right? But so life gets in the way, and people strain and work against their diaphragm, and it forces a lot of things to happen right there, all right? So that's that. Any questions about sphincters? All right. How's my art, by the way, guys? My brother is a walking tattoo. Can you hear me? You guys all right with that? So this is my bad art related to a hiatal hernia, okay? So if you can imagine your diaphragm is this big arch, and let's say your heart is sitting right up there, and your lungs are over there, and your swallowing tube goes through a little hole right here. So there goes your swallowing tube, and in a perfect world, your stomach's right there. So when you take a big breath, that diaphragm does like that. All right, so you flatten the thing out, and the problem is this little arch that's sitting right there gets pulled on. All right, so if you can imagine straining to have a baby. Now, I've been through Lamaze once, and once of Lamaze was enough. So this hole is kind of stretched in the wrong direction. All right, and your swallowing tube is sitting in that thing like that, and here's this big arch, and it does like that. It sort of bows down, so this thing gets stretched. So, and then all the nice little ligaments that hold everything like this get stretched, and your swallowing tube works by how? How's your esophagus? How does any muscle work? It gets shorter, right? That's how this thing goes up here. So your swallowing tube is in there, and it's squeezing, and it will pull itself up into the chest. So all this nice anatomy gets messed up, and your stomach gets pulled up into the chest because your esophagus is pulling it. So when the stomach creeps into the chest, that's a hiatal hernia. I'm trying to think of all the words I've heard used to describe that. But anyway, so when that thing goes up there, this little angle right here I was talking about is gone. All right, so sorry. So you now have, let's say at the least story, it's like that. So you lose that little angle right there. All right, and as this thing starts creeping further and further up there, this sphincter starts to fail more and more. All right, so and a lot of people that have hiatal hernias, if you go down there with a scope, well, this will work. There's no pinch here, so I describe it as looking down a pipe. All right, you just look straight into someone's stomach, and the problem with pipes, if they don't have valves on them, things can go either way. All right, they go down. If you lay down, they can come up. All right. So in a lot of patients, when you do x-ray studies on them, you can see the barium will go down and some of it will wash back up. So it's called spontaneous gastroesophageal reflux. All right? And when things hit here, all right, your esophagus is not made to have acid in there, and that's when you start getting all these various things. And heartburn is just a sign something's going on in there, right? If it's a wide open pipe and you lay down and you've eaten, then stuff can come back up, and people have what I describe as wet burps, or worse, if they lie down, stuff comes up at night and they find themselves wanting to sleep on pillows or recliners and that sort of thing. All right? So everybody got sphincters? High hernias? All right. So what happens if you, well, I'll just say, since this is a woman's meeting, there's another weird thing that happens. It's generally much more often in women than men, and I can't tell you exactly why. There's this something called well, I'll just describe how bad it can get, all right? There's something called a paraesophageal hiatal hernia, and I'm sure no one's ever heard of that, but what happens in some people, the stomach's not really held that much. It's got some blood vessels that go to it, but there are no ligaments to hold it anything in the abdomen. So if you can imagine your stomach squeezing, you'd want it to be mobile. All right? In some settings, because it's not held anything in the abdomen, if this hole gets big enough, and that's a little out of whack, but let's say someone's esophagus is right there and their stomach right there, what happens is it'll actually start to, the whole stomach will creep into the chest, so it actually kind of lays in a loop. All right? So we see, and this is pretty common, 75, 80-year-old woman who shows up and they're not heartburners. And they don't necessarily have chest pain, but all of a sudden they start to notice that the amount of food they can eat gets smaller. So like they get full with about that much food, and then they notice a little pressure in their chest. It's just real subtle, and then they start kind of getting shortness of breath when they go walking. And it's not necessarily it stops them in their tracks. It's just sort of slow creep of ability to function, because food actually gets in this twisted upside down stomach, and it won't get out very well, and it just starts pushing. So and then the lungs get pushed out of the way. All right. So that's sort of a progressive thing. It happens over years, and I've seen X-rays before where ladies start off 15 years before and they have a little hiatal hernia, and 10 years later, you know, there's about half their stomach in the chest, and it's not uncommon. We see ladies who are 85 years old and their whole stomach's in their chest. But the thing is, it's upside down and kind of backwards. So food goes in, and it has to make this big loop-de-loop to get out, and things will just stagnate in their chest. All right? And it's fixable. So paraesophageal hiatal hernia, what that means is the stomach's gone up, and now it's laying up above the end of the esophagus. It's sort of laying beside the esophagus, pushed in the chest. Okay? Everybody enjoying that while they're eating? All right. So you got this thing going on, either a weak sphincter or some stomach starting to creep in the chest. Where's it go? I don't know how many, 18 million Americans are using Prilosec, some crazy number like that. For going backwards, there's Tums, Rolaids, Gaviscon, all those things. They're antacids. And if you're lucky, they'll neutralize a little bit of stuff sitting on the top of the stomach. And neutralize meaning the pH, the acidity of stuff in your stomach is around 3 or 2. I think car acid is somewhere, battery acid is somewhere about the same. It's pretty toxic stuff, the stuff that's naturally in your stomach. Obviously, if your esophagus is not made to have that at all, doesn't take much imagination to figure out how it can burn your esophagus. All right. Antacids, as I said, they coat things. They're surface reagent, right? Wherever they coat, they kind of neutralize acids. But it's hard to get a big volume of antacids into your stomach, because if you take enough Malax and things like that, you're going to get diarrhea, and you can affect kidney function, a lot of other things. Most people don't go down that road. Tums, they're all topical antacids. There was originally Pepsid, I think 25 years ago or so, maybe a little bit before that. It's a medicine that works kind of like Benadryl. It's a histamine inhibitor, all right? And histamines drive acid production. And if you take Pepsid, you can knock out about 30% of your acid production, which ain't bad. It only lasts about 4 hours, sort of as the peak. So the problem is, if you wanted to really control acid reflux, you have to take Pepsid a lot and often. And in the good old days, that's the way it was. You take your Pepsid 3 times a day and try to live with it. Then Prilosec came around. It's been about 22 years or so. Prilosec works a little differently. It inhibits the cells that produce acid. By the way, Zantac and such works on this histamine receptor system, which is a little different. Prilosec works on the actual mechanisms that kick out acid. So Prilosec knocks acid production down somewhere around 80% in a perfect world. All right, and so it works well. For people with mild reflux, meaning they have intermittent boiling up of things and they don't use a lot of those things that aggravate your sphincter, a lot of folks can do fairly well with it, live in balance with Prilosec. There's this weird thing, there are cells in your stomach that are sensitive to whether acid's there or not. And if there's not acid there, then they start making more of a hormone that tells the other part of your stomach to get to work. All right, so like your body's going, where's the acid? You need it. So what happens a lot of time with Prilosec, and obviously there are a lot of other medicines on the market now that mimic what Prilosec does, but your body tends to get used to it. All right, so if somebody has fairly dramatic reflux, meaning their sphincter is pretty worn out, or they have a hiatal hernia, people get in this sort of chase with Prilosec. So it works well for 2 or 3 years, and then your body tries to outdo it, and you can actually track these hormones that drive the stomach to do better. And eventually, a fair number of people end up finding that it's not lasting the 24 hours they used to advertise and that sort of thing, and they need it twice a day. There's actually not many studies that show that it actually works, but I can promise you, I haven't been in this for 20 years, there's a bunch of folks walking around with Prilosec twice a day. There are some people who find that after 6 months or so of twice a day Prilosec, their body tends to start outdoing it. All right, meaning it's very busy trying to compete against the medication. There's some newer ones out. The last one that's out is called Dexilent, and it's very expensive, but it has a prolonged half-life, meaning it lasts longer, so people can get by theoretically on 24 hours. Nexium, which says 24 hours, it lasts about 16 hours. So the presumption is if you take it in the morning while you're eating, when all the real work on your stomach's going on, that by the time you get to bed, you shouldn't need the stuff. So once a day theoretically works for things like Nexium, but there are a fair number of people who at night, they still have problems, so they need something that works during the night. But anyway, Dexilent theoretically lasts longer. It's non-generic, so it's expensive, and insurance companies don't like paying for it, but that's the way it is. And so because of the insurance wars, they sort of drive people back to Prilosec, unfortunately. All right. So what else can you do? There used to be some medicines that would make your esophagus squeeze stronger. In theory, make that sphincter work better and make your stomach squeeze better so things go this way instead of that way. But every one of them that they put on the market has pretty major side effects. So there's some drugs, one called Propulsid used to be around, and it's associated with heart attacks, so you can't get it. There's one called Reglan that affects your nerves, and people get crazy tremors, so you can't get it. And so basically there's not a great medication to make this muscle work better. All right? Yep.
What do you think is the best medication for acid reflux or GERD?
I think it's a knife, actually, but I think Prilosec works well. And if you go out to the big scientific meetings, there's a lot of folks say, well, you know, there's not enough science to say that one's really better than the other. The problem is your body, and people react to one med maybe better than another. There's like 7 of them out there, and I've call it medicine shopping with my patients. We'll try one for a month, and then another one for a month, and then another one, and try to dial one in. The problem is, as you go along, insurance companies start getting mad at you.
I've been on Prevacid a long time.
Yeah.
2 a day and Zantac at bedtime.
Yeah, so that's a good trick, by the way. The reason you do that is because Prevacid doesn't last as long as you want it to, and Zantac works differently. So sometimes the combination may help. All right. You're doing the best you can with that, right? And there's actually no scientific data to say that that's the thing to do, but there's studies out there, people on Prilosec twice a day, 30% of those people make more acid at night. There's something about sleeping, and it causes some acid secretion, all right? So Zantac's sort of the hedge your bet thing, all right? And when you get tired of it, you can give me a call. But anyway, so that's sort of the way it is. All right. All right. So what happens if you don't treat your acid reflux? And there's 2 tricks to this. It's kind of interesting. The number one candidate for esophageal cancer is a white male, 50 years old, who's had reflux for years and maybe or maybe not has taken medicine for it. All right? And the deal is, first of all, guys don't listen to doctors. And guys figure, well, it's just a little gas or whatever. But if you can imagine acid irritating your esophagus consistently, the lining of your esophagus is very similar to your skin. And it's just not made to have that stuff there. All right? So you can burn it. So it's called esophagitis. You can get ulcers. And so there's different grades of it. We grade it 1 through 4. And one's just a little bit of a burn, and it just gets worse until they're active ulcers that are bleeding. If you do that enough, you can get scarring, and then you get what we call strictures. And they can be stretched, but the problem is that the underlying problem is still there, be it a weak sphincter or a hiatal hernia or both. And then there's this creep towards cancer. And so one of the things that happens in the esophagus is, if you burn it, there's a small group of people where the esophagus tries to outdo what just happened. So it actually changes the way the cells look. Instead of looking like the cells on my hand here, the squamous cells, they actually start looking like stomach cells. They develop, it looks kind of like velvet, all right? And there's a fancy name for that. But this process can kind of creep up the esophagus, and it's called Barrett's esophagus. Anybody ever heard of that? So it's considered pre-malignant. All right? And not everybody that has Barrett's gets cancers, but it's a sign that somebody's been having reflux for a long time. In a certain percentage of those patients, the cells, are already overgrowing a little bit, but if the inflammatory process persists, you start getting a change in the cell growth. So the cells start overgrowing more and more, and they become different than their neighbor, meaning one cell is growing faster than another, and we call that dysplasia. And if you keep it up, it can progress to a true cancer. So people who have Barrett's, have been having reflux for a long period of time. People who have Barrett's, and you find it, if you're lucky, because somebody said, okay, you've been having reflux for 5 years, go get a scope so we know what's going on. If you're a guy, you just blow the doctor off until you have the cancer. But if somebody has Barrett's, and they haven't developed this dysplasia, you can watch them, but treat them, all right, with acid medicine, and that's sort of the standard. There's some argument that people with Barrett's don't have the cells in there to tell the brain you're having reflux, so you can have non-symptomatic reflux, so it makes it hard to tell whether your medicine's working for a Barrett's patient, but that's where we're at. And if somebody progresses and they have dysplasia, what that means then is you get to have biopsies done fairly regularly to make sure there's not a progression of the disease to advance towards cancer. There's an initiative program over at Chapel Hill, and they were one of the first people to do this. They have something called radio frequency ablation. And it's a device you put down in the esophagus, kind of lays up against the esophageal wall, and it moves very rapidly. You can barely tell it's moving, but it creates local heat. And you get a very superficial burn across a broad area of the esophageal wall, and you can burn this tissue. And about 85% of the time, you'll grow back squamous cells. So it's actually a process being used now to try to prevent the progression to cancer. And they're trying to decide at what stage do you start it. If somebody with mild dysplasia, moderate dysplasia. If somebody has high-grade dysplasia, the odds are there's a cancer hiding somewhere in there, and those patients get their esophagus removed. All right? But theoretically, this ablation process, if you get ahead of the curve, you can maybe prevent cancer. There's another freaky thing. The incidence of esophageal cancer has actually gone up consistent with the time that Prilosec's been available. And there's this weird thing that there's a school of thought out there that Prilosec, if it neutralizes acid, which is great, the other thing that's in your stomach juice is bile, which comes from the intestine just below that. And if bile gets into your stomach, then it can get into your esophagus. And as it turns out, bile is just as irritating as acid, and it may actually be worse in terms of stimulating the process of cancer development. So there's an argument going on out there. It's like, how long should you leave somebody on Prilosec? And are you actually increasing the risk for cancer? Nobody quite has an answer about that or exactly where that's going to go. Prilosec is not off the market, and it's not going to be for a long time. But it's an interesting issue related to esophageal cancer. Cancers used to be because you smoked, esophageal cancers. I trained in Charleston, and we had a cancer unit, and everybody had squamous cell cancer, which is because the cells of the esophagus look like the skin, don't like cigarettes and the nicotine and all the carcinogens that go with it. But today, the number one cancer is adenocarcinoma, which comes from this Barrett's, which comes from chronic acid. All right? A lot of folks say, well, gee, if I have esophagitis, should I be worried about getting cancer? The incidence of esophageal cancer is not that overwhelming. And most people that have reflux won't get it. Most people that have Barrett's won't get it. It's just that, it's out there. All right? So when I see patients, I try to get them, don't think about cancer, because it's really not the big thing. It's the quality of your life with your reflux. So, what else can I tell you? Surely I know something on that. I think those are the big things. And then I don't know if you guys really want to know what surgeons do or not. I'll be more than glad to talk to you about it. But I think that's really the state of the art as far as medicine is concerned. You can't do things that provoke it, and you shouldn't. And you should take the medicine. And what I tell patients, first of all, if somebody has a short event of reflux, one of the arguments is, how long should you stay on medicine? And generally we assume that there's some sores down there, so you take it for 2 months. And if it's just one blast of acid that really irritates things, it should work. People who have long-term reflux, I've had patients say, well, I'll just take it when it's bothering me. So let's say you take it twice a week. Well, the odds are you're refluxing every day. And if you leave it going like that and you just take it when you're feeling really bad, you're probably under-treating yourself. All right? So I personally strongly encourage patients to take it every day if they need it once or twice a week, because the odds are they're just not managing their problem very well. And it is expensive, but it's better than having your esophagus have sores and get strictured and all the bad things that can happen.
If you have a hiatal hernia, is there anything in particular to treat that?
Yes. So it's an anatomical problem. And when I describe reflux to people, I tell them, you have a physiologic and probably an anatomic problem. Physiologic meaning the sphincter is not working, or your esophagus is not pushing things down well enough once they come up. Or it's anatomical, meaning your stomach's creeping up into the chest, right? So for anatomy problems, you have to fix the anatomy, right? And so that's what I've spent the last 20 years trying to figure out how to do. I'll talk a little bit about surgery. Surgery been around for reflux disease 50 years at least. And when I first got involved with this, I remember walking down the hall and watching patients get their esophagus stretched with these rubber hoses because they've had scars, because they've refluxed for so long, and patients just live with it. Because the doctors back then said, well, you should never have your hiatal hernia operated on, because it's a terrible operation, it may kill you, and it's going to fail. All right? So in the good old days, you'd get a slice between your ribs, spread everything apart, and go up and get that stomach out of the chest and repair the hiatus from inside the chest. And or you got a pretty good whack here to put your hand in there and pull the stomach down out of the chest and repair the diaphragm from the inside. And the natural history of a diaphragm repair is such that they fail maybe 30% of the time, maybe 40% of the time. And there's both in the good old days and even with laparoscopic surgery. And the main reason is, you can imagine, let's say some surgeon closed this hole down in your diaphragm and you walked out into the recovery room and retched a little bit because you're nauseated, or you go home and you start coughing really good. Your diaphragm is sitting there trying to undo what the surgeon just did, right? So that's an issue. So that's the first problem. And then the next problem is, how do you create a sphincter when there isn't one, right? So that's really some of the issues related to surgery. So how I approach the problem, and I tell people I'm a little different. I believe in cheating, all right? And so if somebody's esophagus is in their chest, all the way in their chest, and their stomach's up there, and so it depends. Some people have a lot, some people not. So here's your stomach. So we do laparoscopic surgery. So we poke little holes in people, And we have a camera system. Nice thing about these camera systems is you can see very small little things, and you can see things from a distance. So you can imagine the good old days, you get a slice like that, and your stomach's in your chest. This is the way we used to do surgery. You'd tear things apart, but you couldn't actually see it because it's up above the diaphragm. So if you did it the other way, you went between the ribs, you'd be kind of doing like this. You go through the diaphragm to try to free things up. So the problem is visualization. But with these nice long instruments, you can put things through this hole way up here, right? So the part of the problem is the esophagus has shrunk. It's up where it isn't supposed to be. So what we do is we go through this hole that Mother Nature has that's too big now, and we go right through here, and right through there, and the sac that holds the lung is here, the sac that holds the lung is there, and on top of that is the sac that holds the heart, and we go around and around and around the esophagus, and we divide these baby little blood vessels and lymphatic channels and such, and we get it so that I'll do it over here. Sorry. So that the swallowing tube is here, the opening is there, and your stomach's back here. All right? So what I do is we set a number, 4 centimeters. All right? So it's about 1.5 inches of esophagus sitting in the stomach without anybody pulling on it. So to get that, we actually go up through this hole to where we can see the blood vessels coming out of the heart going to the lung. So we go way up there. Or I say we, I do. And the reason is when you let go of this thing, you don't want it going back up into the chest. All right? So rule number 1, don't be a weenie. Okay? So the end result of that is that you've got everything out of the chest, and then the next problem is you have a hole that's too big. And that's this thing right here. So the interesting thing about this gap is the top half of that thing up there is really tough tissue. It's fascia. So like that tendon in the back of your foot back there, it doesn't give. And we're trying to get it together. So what's done normally is you take this thing and you sew this together right here so that you close it down around that swallowing tube with stitches. And the problem again is this thing is really tight and you're trying to beg it to stay together, and the patient's going to go home and cough or sneeze or do something. You just know they're going to do it, right? So what I do, if you can imagine, there's a big blood vessel going back to your heart right there, and there's this fascia sitting right here. This is where I cheat. I cut the fascia right here, all right? So what happens is this thing springs open. There's a gap right there. And what you can see through that is the fat that's on the outside of the sac that holds your lung, and what sits up here is the sac that holds your heart. And you're kind of looking at them, but you're not where the heart is, and you're not where the lung is. But the nice thing is it takes tension off this thing so the patients can cough. I don't care. They cough in the recovery room. And then what we do is we put a patch over that. And then I put the patch over where I put those stitches right there. So there's this nice patch that covers everything. So things can't go through the hole, right? So the benefit of that is it takes the failure rate from about 30% and drops it down to about 2%, which is pretty good, right? It's not perfect. Patients still cough. Try to outdo this. I've had 4 patients not tear one, but re-stretch that hole. And one had a migraine, terrible. She's a vomiter when she had migraines. I had one guy try to lift an airline engine. He worked at GE. And I had one guy had terrible food poisoning. He called me from Japan. He says, "What do you want me to do?" And one guy had a bad pneumonia, right? So anyway, so that's how you repair somebody's diaphragm so that it puts up with the stress that Mother Nature has. So then the next thing is you want to create a sphincter or something like one, right? Because that's what works, right? A flap valve and a sphincter. So if you get the stomach back down here, what we do is take this part of the stomach and tuck it behind the swallowing tube so it looks like that. All right? So the top of the stomach is tucked behind there, and if you stop just like that and you kind of make it like a hot dog in a bun, you get a flap valve. All right? So then what we do, and in fact, if you stop just like that, you just did a hot dog in a bun sort of thing, you'd stop regurgitation, right? Liquid wouldn't be boiling up anymore. But you might still get a little acid up through there. So what we then do is take this part of the stomach and just kind of lay it over here. And I call it a donut of stomach around the esophagus. All right? And I call that a dumb sphincter. All right? Because my sphincter is supposed to open and close. and that stomach doesn't know to do that. It just sits there. So the trick with all this is to make sure it's not too tight. All right? So you want the perfect world where there's just a little pinch that stops things from going up, but not too much of a pinch so that things can go down. In a perfect world, you fill this thing up with air, and you can burp a little bit. All right? And I have one guy that I did this to who went to ECU. Any ECU graduates here? My daughter went there. Was it a party school when you were there? So this guy got mad because he could only drink a 6-pack of beer, and he got full and he couldn't burp. And he was very, very frustrated with me because his team, when they got together, it had to be more than a 6-pack of beer. So I actually had to go back and cut those little stitches there and get this thing to lay a little bit apart so you could get past the 6-pack. All right? So it is nice to burp, but it is a little harder when you put a good barrier against things going up. All right? So the cure rate with surgery, who was it asked me, somehow it came up about what, I can't remember the way it came up. But the cure rate for this disease with surgery is somewhere around 98%. All right? There's a small group of people you have to take back because the wrap works so well that they can't burp. I've done 6 in 20 years. And there's about 10 I've taken back over 20 years where the wrap worked, but it still slowed down their swallowing to the point they just couldn't get food to go through there as well as they needed to or wanted to. So you can do it. You can stick plastic tubes back in there and cut those little stitches and make it more like a hot dog in a bun. So that's it. So the national failure rate for this, I can promise you, because I know the people who have written the papers, is somewhere around 30% or so. And that's why I consider myself a little different. Like I said earlier, I hate losing. All right, so I hate doing another operation again. It just gets under my skin. So I've spent a long time trying to figure out how to outdo Mother Nature.